Welcome everyone to another webinar in our Contemplative Medicine Conversations series featuring faculty from our year-long Contemplative Medicine Fellowship. My name is David Iozzi. I'm the Director of Studies at the New York Zen Center for Contemplative Care, and I'll be hosting this evening along with Meier, our online programs manager, who will be behind the scenes helping with Zoom. Today, Sensei Chodo Robert Campbell and Sensei Koshin Paley Allison, the co-guiding teachers, welcome, of the Zen Center and the Fellowship, are joined by faculty member Dr. Diane Meier to discuss reclaiming the heart in medicine. Dr. Diane Meier is Director Emerita and Strategic Medical Advisor, Center to Advance Palliative Care. She is also the co-director, Patty and Jay Baker National Palliative Care Center, professor, Department of Geriatrics and Palliative Medicine, and the Catherine Geisman Professor of Medical Ethics, Icahn School of Medicine at Mount Sinai. She's widely regarded as a preeminent change agent and was named one of 20 people who make healthcare better in the United States by Health Leaders Media in 2010. Was also elected to the National Academy of Medicine of Sciences in 2013, and has published more than 200 works in peer-reviewed journals. And is one of our beloved faculty for the fellowship. Welcome, Diane, Chodo, and Koshin.
Thank you.
So the first part of this evening is a free-ranging conversation between the three of them about reclaiming the heart in medicine. I won't be facilitating as we might if this was a panel, so they'll be just having a heart conversation as we do in fellowship in our faculty sessions. And we'll open for questions about midway through. In the meantime, please feel free to share questions through the Q&A feature and the chat feature. And Meier and I will be collecting those for the discussion. So Dr. Meier, Chodo, Koshin, again, welcome. And maybe I'll start you off with a question. You've all spoken about the primacy of human connection and relationship and love in medicine. And I wonder if you could talk about why that is the case and what the impact of centering those is on patients and the practitioners themselves and others. And why are we talking about reclaiming those in medicine? What happened and what is needed?
Thank you, David. That was actually going to be my first question. So we're reclaiming. When did we lose it and where? So that for me is that's my opening question. It's like, when did we lose this?
Yeah. I think my professional career, I graduated medical school in 1977, and it's now 2022. So about 50 years, I guess, or almost 50 years. And the change occurred in that period of time. And it had to do with the corporatization of medicine and the drive for efficiency and volume and subsequently money. So we've moved from a largely nonprofit healthcare system when I finished medical school to one that is increasingly driven by profit motive. And as I have written and said thousands of times, the profit motive and the care of patients are opposed goals. And there's a obvious conflict of interest there. And yet it happened without any public dialogue or debate, without any explicit naming that this was happening. It was roughly 20 years ago, the law was passed to create Medicare Advantage. which was Medicare managed care run by private insurance companies, almost all of which are for profit. And as of now, almost half of all Medicare beneficiaries are in a Medicare Advantage plan, and that's expected to rise to the 70 to 80% range in the next 10 years. So that's the major publicly funded program for healthcare in the United States. And it will be 3/4 for profit very soon. And then partner that with the fact that roughly 3/4 of nursing homes in the US were for profit. That was not the case 30 or 40 years ago. They were all nonprofits. Home care agencies are roughly 70% for profit, and hospices are at least 70% for profit. And, you know, the public has been hoodwinked, basically, because this is their taxpayer dollars paying for this. I mean, it's pickpocketing. And it's striking to me how little dialogue or naming of this sin, original sin, there is in our dialogue. Everyone knows the healthcare system is broken, but this root cause of its brokenness doesn't seem, it's unnameable, it's unsayable at some level. I don't know why.
It's so interesting. I was just thinking about that anthropologist, and I'm forgetting her name in this moment, but she was asked about where's the kind of the beginning of community and care, and where did all love, you could say. And she said that when they discovered a skeleton from thousands of years ago, and the skeleton had a repaired femur. And she said that the only way that that could happen is if the whole community came around this person and cared for them. And so for me, that's so much about what's missing, is that it's the community coming around to, and that means even the doctors themselves, the nurses, like the people, you know, the 75% of people who offer care are, you know, friends and family and neighbors. And it's that, how do we return to and remember together? And because as we've talked about so much, is about this culture of isolation and loneliness, and that it just keeps getting more and more fractured. And so how do we bring it together so that we can repair that femur?
Well, the work you are doing is a key, a central part of the solution, because it lets us practice being present and being with each other. Whereas if you're working as a doctor or a nurse or anything else in the healthcare system now, everything is transactional.
Right.
And what you're doing is opposing that context with what you do. And I think that skill set is necessary, perhaps not sufficient, but necessary to get people to reject. What's happening, we've got a society in which good health is important because you need to work. And if you can't work, you're not productive and you're not valuable. You're marginalized. So older people who have retired used to have a really central role in caring for children and helping their children care for their grandchildren, and relaying the wisdom of the ancestors and providing wisdom from a lifetime. And now everyone's locked in their apartment trying to figure out how to do Zoom, and they are viewed as a burden and view ourselves as burdens. Because if you're not part of the transactional machine, we don't need you. And it's there's a book coming out soon by a woman named Becca Levy, who had an article in yesterday's New York Times about her, that her research is about, what she found is that people who buy into ageism and believe that as we get older, we become, worthless, essentially, die much sooner, are much sicker, have more dementia, have more depression, and sicker in every way. Whereas people who are positive about their aging and hopeful and engaged and in the world live longer. And so I don't know why we would have to need that proof. Why do we need the fact that they live longer to say this is important? But
we do.
It's proof of the mind-body connection. It's proof that human connection is essential for health, and well-being and survival. And, maybe in our transactional world that will penetrate. Who knows?
But, herein lies the rub, though. We are living now in a culture and society where we have to work until we drop, basically, most of us, because we can't afford to not work. And I'm speaking for myself, I can't afford to retire, so I'll be working till the day I die. So there is this, there's this gap, who is going to take care of our elders, the elders that can't work? Who are the caregivers that are working? They need to save, they need to earn money to be able to just survive, and they're not able to stay home.
Right.
It's like, we're in this real tricky conundrum. It's like, yes, we need, whereas like 50 years ago, the family would take care of each other. Now we're all working, it's tough. It's really tough.
Yeah. And, again, in prior generations, extended family raised children.
Mm-hmm. Exactly.
And parents might be hunting or gathering or cooking or washing clothes or whatever they were doing, but they didn't have to worry about childcare.
Right.
And now, the whole COVID dialogue is about distraught parents trying to work on Zoom with a 2-year-old in the same room because their parents can't be there because it's dangerous. And child care is a burden.
Mm-hmm.
Right.
Mm-hmm. Mm-hmm. Mm-hmm.
Well, it's almost like because there's this lack of remembering, there's this huge gap between what we actually value in ourselves and what we're actually doing. And there's a gap between what we, as even a society, we say we believe and care about, and actually how it works. And so to me, it's also I know reading bios is not always so fun, but I think that I was just appreciating, Diane, what you have done in your life too, is about feeling, you can speak to it as you have many times, but about going from seeing this problem and being mistreated for seeing the problem and not appreciated for seeing the problem, and saying, we have to do something about this. And now, in the creation of these organizations that actually are tending to and moving in the direction of, because I think one of the things that we're really interested in terms of the fellowship is like leadership, but how do you lead with nourishment? So how do you lead with, and how do you develop your people so that you're not alone
Right.
in your leading? And how do we really learn how to receive and to give equally? So I just wonder if you could speak to the joys and challenges of that. Because I feel like so much of your work is actually about loving people well.
So I'm reminded of a quote from a man named Avitas Donabedian. I don't know if I told you this before. Okay, so he
No.
is the father of the modern quality measurement industry. You know, he came up with the concept that to have high quality healthcare, you need structures. So you need, for example, you need an X-ray machine so you can take an X-ray. You need processes so that the right people are identified and receive the X-ray. And you need outcomes, meaning that when the X-ray finds something treatable, that it actually gets treated and the patient gets better. So Donabedian got colon cancer and was living in Ann Arbor, Michigan, and was admitted to the University Hospital there and was interviewed by a man named Fitzhugh Mullen. And the interview is in Health Affairs from like 20 years ago. And the interviewer asked him about what his reflections were on quality now that he was on the receiving end of healthcare. And it's a long quote, but the punchline is the secret of quality is love. Because he said, without love, there's no reason for doing what you're doing. And there's no commitment to getting it right, because the commitment to getting it right comes from love. So if you don't have love, there's no quality. And I thought that was so profound. The secret of quality is love. And, you know, it should be a banner in every hospital. Just to remind people that it's not an extra, it's not extra credit, it's the thing itself.
Right.
So on the question of leadership, it is the most important thing, right? Because people are getting beaten into submission by this very broken system and our whole society. You can see it in our whole society, the polarization, the fragmentation, the hatred, the anger, the reactivity, the contempt, the dismissiveness, the stigmatization. It's, look at Zelensky in Ukraine. It's leaders that can cut through that and can remind people of what really matters by naming it and acting on it. And when you name it, it's so clear and so obvious. I mean, the entire population of Ukraine is behind him. And they were not a particularly unified population before. But he's naming these fundamental truths about their country and their right to live in peace. And no one can argue with it. And everyone's behind it. So what is it that makes it possible for him to do that? Why was he able to step up at this moment at tremendous personal risk and risk to his family? It's love. The love he feels outweighs his fear and it enables him to act.
And how about you?
How about me? You know, someone else would have to say. I think that is the root of my motivation. I hope. It's, you know, I think it's a universal human instinct to go towards suffering and to try to relieve it, just as this Stone Age man with the broken femur. You know, the whole tribe stopped moving, they stopped hunting, they stayed where they were so that he could heal. They fed him, they didn't just leave him to die. it's biological, it's evolutionary,
Right.
that interdependence and that
Mhm.
valuing of our community. It's remarkable that something as trivial as capitalism could destroy it. Because
Yeah.
it's greed. Like, why is greed so more powerful?
Right.
I don't understand it.
What about you, Koshin? Where do you come from? Work. What's your motivation?
Oh, it's definitely love and service. I mean, it just feels it's the only thing that makes sense. And I think, I was just thinking about, all these amazing fellows who are in the fellowship, and that it feels like love and service together feel like a direct food program. It's actually like, it's kind of like what you and I have done, and just listening to doctors and nurse practitioners and folks, just like what is actually needed, and just this sense of division and loneliness and desperation out of this incredible field where people are entering the field to be loving and to care and to be of use. And so I feel like pretty much everything I do feels like it's motivated from a sense of what would be loving, what would be helpful, what would be nourishing both for myself and others. And to me, it's such a beautiful thing. I was just with one of our team members, we're walking in the park together for our supervision today. It was so great. Like I said, it's such a beautiful day. Let's walk and talk. And also because here in New York, there's the cherry blossoms are happening. And so I said, let's go and see. And just to be able to take those moments to pause and just look, and to be together in that looking, to me feels very healing and rare. Feels so rare, strangely rare. And that we forget to do these. It's like what most people say about these cushions, like the sofus and zabutons. People say like, oh, it's so hard, but it's like to remember what's most basic, just sit there and listen and experience, actually enjoy your senses. Are you actually tasting your food? Are you actually, to me, that's all part of love too, is actually to really hear. Are you really listening? Are you really seeing? And how rarely we tend to be like, speak like that because we're not really listening. Like those three monkeys, I think about those three monkeys. Boy, such trouble, those monkeys. And yet, to me, together we can say, oh, look, take your hands off your eyes and look. How about you, Chodo?
I was thinking as we were speaking about love is, the turning point for me was back in 1984, I think it was, during the beginning of the AIDS pandemic, where here in New York City, there was so much fear, and yet there was so much love. It's, the first hospital that took in AIDS patients, the first nun that orchestrated the marches, the moves, to be able to bear witness. I was bearing witness to all that outpouring of love, as well as the fear, but it was just so incredible how New Yorkers came together to be in that fearlessness, to be able to sit and bear witness to.
9/11 was an example of that as well.
9/11 was an example. And it's so, I'm not sure how to language this or but there was such a difference. I mean, during the COVID period, the fear, I'm not sure what I'm trying to say here, but it seemed that there was more fear about being with someone in COVID. It's like, wait a second, what happened? we were in the middle of a pandemic. We were in the middle of a huge pandemic in the 80s. 9/11, really woke us up. And then in COVID, it seems like there wasn't the amount of caring for in the population that I would have hoped for. And I'm not speaking about the healthcare system, which is bad enough, but as a culture in general, it's like, wait a second, we have to be out there. We have to be in a community. We have to help those. Again, back to you, Diane, the people living in isolation, the people living in isolation that were dying because people were afraid to go to them or were not even thinking about them. Oh, well, it's just, I have to take care of myself. It's just, what I'm trying to bring to the surface is the difference between, again, it's remembering that we can take care of each other. We can love each other. It's like, I want to share something just very briefly, just very quickly. A friend of ours, just 3 weeks ago, went into a hospital here in New York City for a triple bypass surgery. Is on the phone with his wife tonight. We've been checking in, regularly. I was on the phone with his wife today, and she said, first of all, they couldn't get him out of the hospital quick enough, and the first line on his operative report said, female, 80 years of age. Can you imagine? Female, 80 years of age. I mean, how much attention were they paying to this discharge patient? I mean, it's like unbelievable.
Yeah, that is unbelievable.
Where's the care? I mean, so this man, this friend of ours, and his wife left that hospital thinking, who was taking care of him? If they can't pay that much attention to his discharge, what kind of attention were they paying to him when he was in the hospital?
Yeah. It was probably a cut and paste.
Right. Yeah, well, let's hope the surgeon wasn't
like a standard discharge note,
Yeah.
But it's also so interesting if you were bringing up COVID and this time that we're in, and maybe we're not in it, or maybe we are. It seems unclear. But the reality is that the language, which has always been so, before, as we know, that we're in this, pandemic of social isolation before this pandemic. So that was the pandemic to me, which is still very much here. And then during this pandemic, that language of saying, social isolation, social distancing, make sure you're social distancing. And I wanted to say, don't say that, like what people need to be is physically distant and actually socially more connected. And there's this pain around, I think so much of the language, even before that, people talking about self-care. Go off and do your self-care. Go off and practice your self-compassion. Go off and, and now you have to do distance yourself socially. People don't, but it's getting so ingrained. And what I'm hearing from so many people, both our fellows and just folks, about the fear of being social, of actually connecting.
Yeah.
That somehow connecting socially equals danger.
Well, right. So my daughter and her boyfriend went to a Fish concert at Madison Square Garden on Friday and Saturday. And 3 days later, she has COVID.
Mm-hmm.
I mean, it's real, so, and you're right. It's having not such a temporary impact on people's willingness to connect and be together. There's, 2.5 years of fear of being with other people.
Right.
It's not a week or 2 weeks. It's
right.
Yeah.
And how do you do that? And how do we find ways to be socially connected in safe and thoughtful ways? And how do you actually learn how to, and how do we nourish that in each other?
Yeah.
And define what's nourishing as opposed to don't.
As opposed to frightening.
more and more fear. And it's like all tangled up. And there's this beautiful quote from, an early text from the Buddha where he says, the whole world is tangled in a tangle. Who will untangle this tangle? So it's like nothing new about everything being kind of screwed up. And it's up to each of us, to me, and collectively. And how do we, again, find those circles of true connection where we can untangle it together? Like that greed you were talking about, Diane. It's like we can actually address that. How do we address the greed?
You know what I want to recommend is I've been on a George Eliot kick recently, and I read The Mill on the Floss, and then I went back and read Silas Marner, which I had not read before. And in Silas Marner, he's a weaver who was thrown out of his religious community because of a false accusation from someone he thought was his friend who betrayed him. And he went to another community and was completely socially isolated and sold his weaving for money. And in place of relationships, he had these gold coins. And he would look forward in the evening to running his hands through the coins and stacking them and seeing how the firelight reflected off them. And it was in place of love and in place of human connection. And that was like a light bulb moment. That's why there's greed. It's substituting for something that's not there.
Right.
What happened? I don't know. Anyway, I commend that book to you. I was like underlining every other line.
Diane, what's the name of the author with the book who's coming out tomorrow?
Becca Levy. There was an article in the Science Times about her yesterday. Where is it? Becca Levy, and it is, I'll find it. She's a scientist. She's done decades of research on this. And this is a book for regular people about the implications of her research.
It's beautiful.
Yeah.
So I understand that we're transitioning now to, is that true?
Yes, thank you all. We will be transitioning, and we have collected some questions. I'd like to start with Dr. Peterson writes, I think I hear what you're saying, Diane. Love has many foci. How does one refocus love for money with love for others, regardless of money? I realize that money is needed. Is there a way to reappropriate money to make the transition to loving each other?
It requires a different societal structure, where everyone has an adequate income. Everyone has what they need. And that's the priority, as opposed to the freedom to make infinite money at the expense of other people. So, our religion in this country is the freedom to make as much money as you want. That's our religion. Musk is a archetype of that. But there are, mainly in science fiction, but there are conceptual communities where everyone contributes and everyone has enough. Yeah, Breaking the Age Code. Thank you, Becca Lubu. That's the name of it. So I don't know. I don't Not in my lifetime, I don't think.
Thank you. Christine shares that she said, when my COBRA ended and I went on Medicaid, my doctors told me they couldn't see me, mostly very unceremoniously. One doctor's assistant said she would get back to me, and that doctor provided the names of doctors who would see me. How can we acknowledge physicians who display compassion under current conditions and infuse their teams with it?
It means a lot to a doctor or a nurse to have a patient or a family thank them for their compassion. And just name it, recognize it, show gratitude for it. Because of course, that's why everybody went to medical school or nursing school originally. And that's what makes the work wonderful and nourishing. It helps to have it named and appreciated.
I've had 2 surgeries this year from 2 different hospitals, and within a week of being home, I got these surveys, asking how the hospital was, how the nurses and doctors were, and that, luckily for me, I had really, really great care in both hospitals, and it was such a pleasure to be able to say, to name the nurses, to name the assistants, to name the doctors, just like, yeah, they were great, they were wonderful. And I think those are really important things to be able to do, to as you say, Diane, to let a doctor know what a great job they've done and how much you appreciated it. Because that, as you said, that's why they go into the profession, to make people well and to feel well in themselves, I think. It's like, you give love, you get it back.
Exactly.
One of our fellows in this year's program, he is an oncologist specializing in breast cancer out in Boston. And he was a Zen practitioner, but ironically, he hasn't thought of bringing his meditation practice into the hospital. So over the last 9 months, he has, he broke through that barrier, his fear of doing it, and has now a regular meeting with 10 of his fellows, 10 of his colleagues, to meditate once a week. And 2 weeks ago, he asked me if I would do a session with his colleagues and his boss. And so I asked his boss, I said, why do you want to do this? And he said, I've noticed the difference in my staff in the last 6 months. And he said, it's really, really amazing to see how they've changed, just because they've, meditated 5 minutes a day, 10 minutes a day. So there is there's hope somewhere along the line there.
What did he notice? What did he notice?
He noticed actually that the doctors and the nurses their conversations between themselves was different. They were actually listening to each other. There was less kind of animosity between them. There was more of a collegiality between them. And he said
kindness.
Kindness, yeah. In the team meetings, it noticed mostly in the team meetings how they were relating to each other. Maybe they weren't agreeing with each other, but they were disagreeing in a different way, which is pretty phenomenal if you think about it.
Yeah.
You could disagree, but you could do it in a way that's not harming.
Thank you. And maybe staying on that theme, one of the principles of the fellowship is community, and fellowship in the sense of community, which you touched on a little earlier, Koshin. How can colleagues support each other in creating connection and community, and a sense of what you're talking about, a shared experience or mutual support to, support one another in making a change like this?
Well, for me, you know, I think of Taronia Lodog, who's the other guiding teacher of the fellowship, and she talks about the five. And I always found it so helpful. And she said, you need at least 5 people who are, no matter what, will show up for you and be there. And they may not agree with you, but also, again, they love you. And they will drop everything to be there. And so what I've seen in the fellowship itself is that people are starting to develop those 5, in particular, like colleagues who, you know, maybe their relationships when they entered this were pretty like dicey. And their personal relationships, the relationships at home with their kids, and just feeling that there was this real struggle with, and this idea of this work-life balance, which of course is impossible because we only have one life. And so what I'm seeing and what has been, I don't know, delicious to see is like that people are really developing relationships of support, of true support and love, where they're actually caring for one another.
Sorry.
With a little music.
This is our life.
Yeah, but it's just, but they've been caring for each other, you could say, with music, and but also the music of actually paying attention and kindness. You know, it's really beautiful. That I think it's actually, and I think of what Taronia actually does. She, for her patients, she writes it on her prescription pad. She's like, but you have to fill the prescription. Like, find and develop and nurture your 5 people. If you have none, that's okay. But start with 1. And we want to build up to 5, you know? And so I think it's just, requires intention and putting ourselves, like getting to the end of the hokey pokey, where you're putting your whole self into what's actually important. So that gap between your values and your life, you know, we just start with a rope bridge maybe and bring it together. Yeah.
That's lovely.
Diane, there's a good question here from Susan. I think you might be able to answer, or I would love to hear your answer. Do you feel it's possible to allow and support practitioners to be more compassionate with their patients without changing the current fee-based model of healthcare?
I am teaching as if it is possible. Because people can choose. It's like what Viktor Frankl wrote in Man's Search for Meaning. So he was in a concentration camp in Auschwitz, and he wrote that they could not take away his inner state, his inner stance, his inner reality. And that's what I'm trying to teach to medical students and interns and residents and others that I have the privilege of teaching, which is that they can, and meditation skills really help here, put aside the enormous pressure to see one patient every 5 minutes and document 55 different things and close your charts and take a breath before you go in the room, take 2 breaths before you go in the room, sit down, don't cross your legs, don't cross your arms, open body posture, make eye contact, and introduce yourself.
Mm-hmm.
And ask the patient to tell you about themselves. And so it's a learned repetitive behavior that I think it's a discipline. And it's a meditative, it's meditation that creates the capacity, I think, to create space wherever you are, whatever you're doing. So, yeah, I think meditation skills are key to giving love in the clinical encounter, because you do have to protect yourself from the noise
Mhm.
in order to connect with the patient.
There's a question, I'm sorry to put you on the spot again, Diane, from Fernando Kauai, who is a member of our community, a doctor at Columbia Presbyterian, or in Queens, I think. And he says there are 76 million baby boomers in this country that will continue to age and die. But we have such a small number of palliative care, geriatrics, and contemplative care practitioners. What advice do you have to the small number of providers as they face the immense task of caring for our aging population and try to promote change?
So so the answer is it depends, of course, on you and who you are. And so self-knowledge is necessary to answer that question. Like, what aspect of your life brings you the most joy and makes you feel like you were put on this planet to do this thing? And that is a discovery, and not everyone figures it out by age 25. It took me until I was in my late 40s to figure it out. So whatever you're doing that isn't it is preparation for it. It's not a distraction from it. It's a process of getting there. And then you kind of figure out your highest and best use. And then your task is to push the barriers away that are keeping you from doing your highest and best use. So in Becca Levy's case, it's, she's a scientist writing a book for the public. So her highest and best use is this process of understanding the tangle and trying to show how to untangle it for her fellow humans. For people who are master clinicians, it's the care of individual patients. For people who love mentoring and connecting with the next generation, it's teaching. That's where the joy is. That's where the highest and best use is. So the answer to your question is it's finding your highest and best use as a geriatrician, as a palliative care clinician, as a contemplative care practitioner, and getting yourself into that place so you can do it, because you will do the most good if what you're doing is an expression of your highest capacities and passions. I think. So I don't think there's one right answer. And I think when people encounter someone who is living in their highest and best use, it gets recognized,
Right.
And people are attracted to that genuineness, that clarity.
It's so enlivening.
Yeah. It's so simple. It's so
Mhm.
not distracted,
Thank you. We have an anonymous person who wrote in that as a medical student, I have also seen the discrepancy in what we value versus what we are doing. Can you share some advice on coping with a field that has changed to being profit-driven and insurance-dominant? How do we keep alive our enthusiasm and compassion? And without this person's permission, I'd like to add a related question, which is something we hear a lot, that if clinicians sometimes feel if they open their heart, if they connect, that it's a kind of zero-sum game, that the patient benefits, but they burn out, empathy burnout, compassion fatigue. Can you also speak to that as it relates to keeping alive your enthusiasm and compassion?
I think the opposite is true. Personally, that genuine human connection in the clinical encounter is nourishing to everyone involved in it. It makes you happy when you go home at night that you had that. It reminds you why you're lucky to be a clinician. Certainly not the money that's telling you that you're lucky to be a clinician. So I think people are afraid that it will take too much time, and they've got, this hot breath of, you've got 25 people in the waiting room, move. Someone knocks on the door and says, "Doctor, you're an hour behind," this sort of no-win confrontation with the medical industrial complex. But again, it's an inner discipline to push that aside and connect with the patient. And it might be that you can't have an hour with the patient, but you can have 10 or 15 minutes with the patient. And those 10 or 15 minutes can be real instead of running down the review of systems, throwing a stethoscope on the chest, doing a reflex, documenting it. That is a pointless ritual, right? That's so you can bill, you do all that stuff. But the real value of the encounter is the human connection and the trust that has to be present for you to be able to help a patient.
Yeah, I wanted to just address that piece of, the point was, if you open your heart to the patient, then you're going to burn out. And in work that I do, which is mainly with people who are dying, as they're actively dying, as a priest, as a chaplain, people say, how can you do that work? How can you be with so many people who are dying? And the reason I can do it so beautifully, I say for myself, so is that I will open my heart and be in real connection with that person. It's not about closing up because I don't want to look at death. It's about really being with, bearing witness to, and going home at night and saying, what a profound honor this is that I can be with someone at the end of their life and just listen. And that's all I have to do most of the time, just listen, to hold a hand, and to just, eye connection. I see you. I see you. That's the most important part of the work for me.
Attention.
Yes.
Attention is the most precious, infinitely valuable thing on the planet. And, these things are attention destroyers. And the transactional culture that we live in is an attention destroyer. But cultivating the ability to pay attention and give attention to another person, nothing else matters.
Simone Weil said, attention is the rarest and purest form of generosity.
And it doesn't take long, right? I think that's the other thing. I remember, rounding to on this oncology ward, and this woman who I was working with, I'll call her Betsy, and she was like, "Oh, have you met the new medical student?" I said, "No." She's like, "She's amazing." I said, "Well, what's amazing about her?" She's like, "You'll see," because then they come rounding, which means they literally surround the bed and often talk about the person as if they're not there. And so they came around, and they came around the bed, and this young woman, the doctor, medical student, was just looking at her and just smiling. And then she left, and they all left down, and she's like, and then Betsy just turned to me and she said, "Wasn't that delicious? It makes me feel so much better." And I had a chance to catch up with the medical student. I said, "How is that for you?" She's like, "Oh, I look at everybody and just imagine what they're feeling and just sending them some love." And I said, "Well, some people worry about that." And she said, "Oh, then I can leave the hospital and feel like I've loved so many people." you know, as opposed to like, we can spend so much time, you know, hunkering down, afraid to feel, and then we're just afraid. And to me, loving is just like, how do we just open up into something wonderful? Just a gaze. And it took they were there maybe a minute and a half. And it changed Betsy's life.
And that's the point.
Amazing. Thank you all. I unfortunately have to play timekeeper and share that we're at the end of our time here. I want to save a few moments for the three of you to close. And before that, I'll just make a few announcements about this webinar and the fellowship. We've been recording this and we'll share the recording with all of you in an email. Please feel free to share it with colleagues who may not have been here. And for those who are physicians, nurse practitioners, and physician assistants and are interested in applying for the fellowship, we're accepting applications for the fellowship, which begins July 30th. And application deadline for that is June 15th. I believe Meier will put into the chat a link to our page for that. And for those who are clinicians in other professions, or those who are interested in exploring the intersection of care and your spiritual practice, we also have our 9-month program, Foundations in Contemplative Care, which is also accepting applications. Our next webinar is May 16th with Sharon Salzberg, American Buddhist teacher. And also before that, we want to let you know that if you are interested in the fellowship and you have questions specific to applying, we're holding an information session this coming Monday, May 2nd, where you have an opportunity to ask questions of Koshin, Chodo, and we'll be joined by one of our mentors and some of our current fellows who also share about their experience. So Meier will also put that in the chat. So all of this is on our website. And again, we'll also share it in the email following this. Dr. Meier, Koshin, Chodo, please, any closing remarks you'd like to share?
I'm grateful for feeling so connected to you, even on Zoom. Sometimes the words and the image are what you need. It's a gift tonight. Thank you for the gift.
Yeah, I also just I feel very loving towards you, Diane, and to you, Yotzi, and Chodo, and Meier, who's sitting here. And for me, that's really, it's like that wonderful teaching from the great Bodhisattva, Albert Einstein, where he said, our work is just to keep expanding the circles of compassion and love, so it's just, how do we just keep doing that? And I don't actually know what could be more important or urgent, because it's actually what's life-giving, and it actually is the medicine for fear. It's the medicine for loneliness. It's the medicine for greed. And just to realize that we can show up differently. So I'm just so grateful. Chodo?
Well, I have to say that I admire your capacity for love, Koshin, because you kind of exude that, and you love so many people. And it's just, that's who you are. And I just have so much respect for you, Diane. I mean, we've just known each other for so long, and that's love right there.
Yeah.
We've maintained this. And also, the Zoom thing, one thing that's come out of COVID is now the capacity, the ability to reach so many different people on Zoom from across the globe. It's just so, I mean, I found, ironically, it seems like this thing between us, this screen is, I don't have to get so close to you, but actually I've found that people actually become more vulnerable because of this feeling of safety. It's such a gift. It's like, wow, do you know where you're going right now? It's beautiful. So there's so much love coming through the screen so often. So
I've experienced that too.
isn't it amazing?
Yeah,
People
it's counterintuitive.
right, exactly. So I have to say, I'm loving Zoom. All right, thank you, David. Thank you, Meier. Thank you, Diane.
Thank you, everybody.
Have a good night. Thank you.
Thank you all.
Good night.
Just this evening.
Good morning.
Good morning in South Africa. Good to see you.